ever hold your peace. Right. So we're going to hear today from Community Solutions and the Institute for Healthcare Improvement, just an overview of what they do and the work that they do around homelessness, and especially the Healthcare and Homelessness Pilot that we've been doing for the last year and a half. So with that, I will pass it over to whoever wants to go first.
I think that's going to be me.
Do you need to control the PowerPoint?
I do not. Do you have control power? I just have a few slides and
Yeah.
I'm going to talk for a while before we change slides in the beginning.
I'm just gonna click it. Wonder if Google will let me click that right there. So.
Yeah, so we can actually go right to the next slide. So hello again, everybody. My name is Taj Brown, like I said, and I am with Community Solutions. I'm currently portfolio lead for our portfolio called Upstream Strategies, which is where our partnership with the Institute for Healthcare Improvement and the Healthcare and Homelessness Pilot has lived in for the past year and a half. And Ben and I are joined by a team of other folks who facilitate this pilot and other projects we have going on in that portfolio. We have a short amount of time today, so I'm going to try and give you a quick history of Community Solutions, get us up to today as quickly as possible, and then Catherine will tell you a little bit about IHI's background. They've been our longtime partner since really the founding of Community Solutions when we transitioned out of the original organization Common Ground, and our embedded partner for this project. And then Ben and Catherine will talk a little bit more about the particular pilot that we are so fortunate and grateful to be in partnership with all of you here in Anchorage through the Alaska Coalition on Homelessness. So basically, we're Community Solutions. We work toward a lasting end to homelessness that leaves no one behind. And our main thrust is our Built for Zero movement. That's where all of our prevention and reduction, homelessness reduction work lives. So I'm gonna tell you about how we got started. It really started in 1990, as you can see in the farthest lane there. Our founder, Roseanne Haggerty, comes out of Connecticut, and she had been volunteering in the summers in New York City, where she was going into shelters and working with primarily initially youth shelters, working with youth who were experiencing homelessness. And as she was volunteering at those shelters, she would come back and help someone get into transitional housing. She'd come back the next month and she would see those people again and again. And she kind of became curious about what was going on, such that people weren't able to stay outside of the shelter system. And so it made her become interested in permanent supportive housing. And so she was able to pull together funds. This is going to sound unbelievable. She was an intern, right, in this shelter, was able to pull together funds to purchase the Times Square Hotel in New York City, which was dilapidated and run down. And I can't imagine how much money that cost to fund. That's not in the back notes they give us. Roseanne was able to raise the money, and she was able to create, I believe, 650 units of permanent supportive housing for people experiencing homelessness. And that all happened under the umbrella of an organization called Common Ground. The idea there was she wanted to create affordable housing for people who in some cases were getting a voucher, but the idea was they would have a lease or a contract so that they could not just be displaced from their housing. So with that vision, she got it going. And then that happened for about 10 or 20 years. 2 decades, they were buying up buildings in New York City and creating permanent supportive housing. And then in the early 2000s, Roseanne noticed that even though she had these buildings, had this initiative to help people transition out of shelter and into housing, she would notice people still sleeping outside of the building. And there was one woman in particular whose name I believe was Rose. And she would ask Rose, why are you out here? We helped you get an apartment inside. And Rose just kind of brushed her off. And then one day, Roseanne got a call from a hospital in the emergency room because Rose had put Roseanne down as her primary contact. And when Roseanne got on the phone with Rose, she said, Rose, what's going on? I thought, you were getting housing. And she said, no, you never really asked me what I wanted. You told me what I needed. And then Roseanne got this idea that what we should do is really help people not just get housing and services, but ask them what their needs are and respond to their interests. And so from there, Roseanne created this organization, Community Solutions, and that was in 2010. And the first campaign of Community Solutions was the 100,000 Homes campaign, which was modeled after IHI's 100,000 Lives campaign. And you'll hear from Catherine a little bit about that. So the goal with this initial effort was to house 100,000 people who were among the most vulnerable populations. And they were able to do that. And that was a big success. And after that time, they realized that, you know, they were able to house, I think it was 105,000 people who got housing through 100,000 homes. But even those people had housing, there was no equivalent reduction in overall homelessness numbers. They thought that, oh, if we house 100,000 people, when you get into the pit count this year, you should be able to see a correlative reduction in homelessness, people experiencing homelessness. And that did not happen. So that was frustrating for them for a while. And then what they did was they took that idea and they said, you know what? Let us, instead of counting up to housing people, let's start counting down to help so we can reduce the number of people who are experiencing homelessness. And that's really where Community Solutions got its idea for Built for Zero. You can go to the next slide. So at the end of the campaign, the 100,000 homes campaign, they pivoted from counting up, counting down, and the explicit goal, of course, was to count down in the people experiencing homelessness. And that was a shift in mindset that really was important. Can you go to the next one, please? It required a pivot. One more. Yeah. So it required a pivot, and that's where we got the idea to build Built for Zero and count down. So Built for Zero really is designed to end homelessness at all population levels. And as you can see right now, we have 105 communities that are participating. So far, since the campaign's been initiated, 147,000 people have been housed. 14 communities have functionally ended homelessness for at least one population. 64 communities have achieved real-time quality data, and 42 communities, while they are still working towards functional zero, have achieved a measurable reduction. Next slide, please. So I just wanted to go through some of the foundations of our Built for Zero movement. Oh, my little thing here is acting a little crazy. Yeah, next slide, please, Catherine. So when we're talking about how to reach functional zero, right? We're talking about what is a complex problem, right? A technical problem is something that's pretty simple. You follow a process, you follow steps, and you get a certain result. A complicated problem is a little more difficult because while there are processes and certain steps, there are other factors which influence your outcome, and you might not always get the certain result. With complex problems like the one we're trying to solve in ending homelessness, there are all kinds of factors that contribute towards not just your process, but also your outcomes. And so while we're trying to solve this very complex problem, we know that we needed flexible and collaborative processes, which is why when we work with communities like here in Anchorage, we bring together all kinds of stakeholders. Next slide, please. So we talk about what mindset is required to tackle these complex problems. And so we start with an end state where we're trying to go and work backwards from it. We don't know how to solve the problem, as you see with the growth mindset. Doesn't mean we can't figure it out, but collectively we know that we can solve homelessness. We also embrace failing forward, right? Testing a hypothesis, failing quickly, being iterative and improving based on what we've learned. And also we have an extreme bias towards action. Just get going, right? Remember, life is what happens when you're busy making 10-year plans to end homelessness. Okay, next slide, please. Next one. All right, so these are the four sort of pillars of the toolkit that we equip people with when they become part of the Built for Zero movement, right? Data analytics, we want to zoom in on the problem. We want all of our decision-making to be centered around the humans and the people who are experiencing this problem. We focus on quality improvement. It's something that our partners at IHI help significantly with. Test and evaluate each idea with an objective data. And then we want to create the conditions for groups to innovate collaboratively through facilitation. And then next slide. So the basis of our Built for Zero activity is about what we call a quality by name list. The idea is that you have to know the names of the people in your community who are experiencing homelessness on a daily, weekly basis. So the four pillars of our quality by name list, and you folks here at ACEH know a lot about the by name list, I'm sure. We're talking about all agencies and programs are being represented, and that the list includes people not only sleeping on the streets, but also sleeping in shelters. We want each person that has an entry to include their name, their history, their health, and their housing needs. We want each person to be able to be followed through the system. We also need to update that list on a monthly basis at a minimum. And as people's housing status changes, their entries in that database also changes. And then we want the data to balance month to month, just like your checkbook balance. Okay, next slide, please. So there are 7 key data points that are a part of our quality by name list structure. Those are inflow, both people who are newly identified as being homeless, people who are returned from housing, right, who were homeless and were housed and are now back in the system, and people who have returned from being inactive. The 4th data set are the actively homeless, right? Those are the folks we know who are currently in shelters or on the streets. And then we have 3 points for the outflow community, people who are placed in the housing, people who are moved to inactive, and people who no longer meet whatever criteria that subpopulation is defined by. Okay, next slide. So yeah, so when we think about functional zero for fixed populations, we're talking about having the number of actively homeless people being less than the 6-month average of those who are placed. And then the next slide. For dynamic populations, we're talking about whichever is greater, either 0.1% of that individual PIT count or less than 3 people. And that's an overview of community solutions.
All right, thanks, Taj. So as a reminder of Catherine, I'm from the Institute for Healthcare Improvement. I'm just going to tell you a little bit about our organization and kind of how we came to work with community solutions. And then we'll talk about the pilot a little bit too. Oops, wrong computer. So just a little bit about IHI. Our mission is to improve health and healthcare worldwide. And our vision is that everyone has the best care and health possible. And we've been doing this work. We actually were formed in 1991. Don Berwick, who's a pediatrician by training, he had been starting to explore this idea of quality improvement, something that kind of came out of industry or manufacturing. A lot of car companies would do that to make sure that they were standardizing the approach of what was coming off their assembly lines. And he had been studying that, talking to some other experts in the field, and started to ask the question, like, could we do this in healthcare? What would it look like to bring this into healthcare? So we got our start really kind of very specifically in the hospital setting, doing a lot of work on hospital acquired infections. So things like ventilator acquired pneumonia, sepsis, things of that nature. That was what the 100,000 Lives campaign that Taj was mentioning, that was the inspiration for 100,000 Homes campaign, came out of that work. So same concept, like it's hard to count the things that don't happen. So it's hard to know, like, oh, you didn't get ventilator acquired pneumonia. So started kind of trying to count back that way. So we work nowadays, we've kind of expanded beyond just the hospital setting. We work with health systems, we work globally. Our headquarters is in Boston, Massachusetts. Actually, I neglected to mention that. That's where I'm visiting from, that area. But we have faculty and staff all around the world. And we do have one other project office in Ethiopia for some work that's taking place there. But our biggest goal is to work around building improvement capability and kind of coaching around capacity by providing people with the methods that can make care better. I keep going to the wrong computer. So just a little bit about our values and kind of like how we approach our work. So our 4 values are courage, love, equity, and trust. So the courage to do the right thing, even in the face of loss or, discouragement. Love, kind of being at the root of all that we do, is thinking about people as human beings who deserve love, and trust. That one, I think, kind of happens on many levels, trusting each other as staff that we're all kind of doing the best we can. Trusting that the folks that we work with are experts in their field, and kind of everyone has something to teach, everyone has something to learn. And then equity as well, kind of this idea that there really can't be quality if we're not taking an equity lens to the approach. We use improvement science, like I said, to drive these results, and we kind of see that health and healthcare can be much better and must be much better too. So this slide just shows kind of the different levels that we work at. Just really quickly, so we in the innermost circle, we do a lot of innovation work. We have kind of a 90-day R&D process that we explore all kinds of health and healthcare related challenges. I think we actually did one in advance of this pilot. Before the pilot officially started, we worked with Community Solutions to do a 90-day cycle. And during that process, we kind of just interview experts, interview people with lived experience, do literature reviews, and just try to kind of put together a draft framework that can be tested. Not all of the innovation projects, I mean, by definition, not all of them go on to kind of be projects, but it's nice to have that space to kind of learn what might work and what might not. Some of the work that comes out of our innovation work, we do go on to kind of test. And I would say this is where the Healthcare and Homelessness Pilot sits right at that kind of precipice of innovation and starting to demonstrate results. So starting really small with the 5 communities that we're working with, and we'll tell you more about the pilot in a little bit. The next level up is educate. So we do a lot of professional development for healthcare professionals and folks outside of healthcare as well. And then inspiring change is the last one. We try to support dissemination of what we're learning to just build the will for this kind of improvement work. So in the case of the Healthcare and Homeless Pilot, for instance, we're trying to put out blogs, or there's been a couple of media opportunities to spread the great work that's happening in the hopes that that'll kind of help paint a picture for other folks to kind of see what might be possible. Just look at my notes, make sure I didn't miss anything. So I think, Lauren, I shamelessly stole this slide from you a couple of years ago, and I suspect I'm absolutely preaching to the choir here, but healthcare, which is in our name and absolutely where we got started, is really only part, and a relatively small part, of what it means to kind of have good health. So over the years, we've been seeing it, and also just noticing health systems kind of shifting from focusing on individual care to kind of thinking about population level care and what it looks like to improve health for the whole community. So we know that there's so many other factors that go into health, socioeconomic factors, the physical environment that a person is in, personal health behaviors, and then you can see the healthcare piece is just about 20% of what goes into that. So, we've just seen a call that if we really want to live up to our mission and our values of improving health for everyone, that we had to kind of think beyond just working with healthcare. Another view of this, again, I just probably am preaching to the choir here, but we just see that social determinants of health are really much bigger, and we've got the top of the iceberg that we can see, but there's so much behind it. And so how can we kind of address those in order to improve health? There's social determinants of health, but also system barriers, and I think that is something that we are working on quite a bit in our pilot, just like disconnection between the different services that are available to individuals, especially people with complex health and social needs. They're just often encounter fragmented treatment silos as they're trying to interact, and the systems aren't talking to each other, and it puts the burden on the individual. So we're working to solve that. Let's see. So just going into, again, a little bit more about how we came to work on this pilot. So another area that we've been increasingly focused on over the years is this idea of complex care. So really thinking about it from, I think, the individual level and also the system level. So on the individual level, what that looks like is coordinating care for individuals, meeting them where they are, understanding what matters most to them, and kind of designing an approach that caters to the individual. At the same time, learning from the work that we do with individuals and identifying opportunities for system level improvements. So this looks like creating those ecosystems within a community, kind of breaking down the silos that I was just talking about to design an ecosystem that better serves individuals with complex health and social needs, and subsequently kind of improves the health of the population at large. But really at its heart, I always like to think of complex care as just good care. I mean, it seems to be person-centered, equitable, cross-sector, team-based, and data-driven. So, I think the theory here is that improving care for this population will actually just improve care kind of overall for the community. It's kind of that notion of the curb cut phenomenon. I'm not sure if anyone's heard of that, but so this was a study that came out of, let's say, University of California, Berkeley, where they looked at the result of putting in the disability community had advocated for curb cuts so that it was easier for them to kind of take their wheelchairs up and navigate through the system. And so they advocated and eventually those got into place. But what they found was that it really made things easier and better for almost everyone, for, parents who might be pushing a stroller, for older people, older adults who, not having to step down from the curb. So that idea that kind of improving something for a smaller group of or a vulnerable population really has the added effect of improving care for all. We still do some of our core work in healthcare acquired infections. We've really shifted focus to this idea of population health. So really accelerating or working with healthcare professionals and their organizations to accelerate population health and well-being. So we do this by this slide just shows kind of a tested process that we've used. It came out of some work we did called Pathways to Population Health. You're starting by building the will within the community, really unleashing that intrinsic motivation with stakeholders across the organization. And I think this is really important. Most people who go into healthcare do it because at some level they really care and want to kind of see the best for their patients. So tapping into that motivation, which can sometimes get lost when folks are feeling burnt out or kind of overwhelmed or don't feel like they see a path forward. Then kind of working together once the will is there to come up with new ideas. So prioritizing innovative ideas and then kind of using a process of starting small, testing them, seeing how they go, and the ideas that are successful, kind of spreading it. And that gets to this last box here. So really executing reliably, sustainably, and equitably the ideas that are showing improvement. And ultimately, if we go down to the 10th step there, even once things have been improved, making sure to kind of track to see that they continue, looking at data stratified by things like social determinants of health, race, and other factors related to equity. So now just a little bit about the pilot overall, and Ben, feel free to jump in, but just I'll kind of transition us over. So, as I was saying, it's so well documented at this point that social determinants of health and social factors are contributing much more to poor health outcomes and premature death than healthcare access alone. That's only one small piece of the puzzle. But even with that, knowing these outcomes, there are definitely bright spots that exist, but we have not seen any kind of clear model yet that guides healthcare and health systems and how they can optimize their resources to drive reductions of homelessness across the community. So I'm going to try to tell the story. I was not there, but from what I've heard, as Taj mentioned, we at IHI have collaborated with community solutions for over a decade, but mostly on kind of teaching around quality improvement. We hadn't really got together in terms of the content. From what I heard at one of the Built for Zero conferences that one of my colleagues was at, they were at the bar after the conference, just chit-chatting, and somebody came up to them and kind of called them out and said, "You've got IHI with all your experience and connections in healthcare. We've got community solutions with your work on Built for Zero. Why the heck aren't you guys working more closely together to try to see how healthcare can factor in there?" And they were right. So we came together. and started building out what this looks like. We also leaned heavily on this concept of an anchor mission, and this comes out of the Democracy Collaborative. But it really suggests that, or emphasizes the commitment of deploying long-term and place-based economic power, people power, and other resources to better the long-term welfare of the community in which the institution is anchored. And, you know, as we all know, hospitals and health systems are big businesses and big anchor institutions in the community. So the work of this is really our goal with the pilot is that we'll learn together with the 5 sites that are involved. And I should say, in addition to Anchorage, we have Sacramento, California, Bakersfield, Kern County, California, Washington County, Oregon, and Chattanooga, Tennessee. Does anybody know that's that are working with us on this project? So learning together, and ultimately our goal is that by the end of the pilot, we'll have a better sense of what a scalable model might look like that can be deployed. One other thing, and then maybe I'll pause and then see if you have anything to add, but oh geez, I just lost my train of thought.
Sustainable, scalable.
Yeah, sustainable. and scalable. All right, you know what? Why don't I just sorry about that. I'm sure it'll come back to me. I'm going to blame the jet lag and time zone difference. But in order to get there, we did kind of develop a draft theory of change that came out of that innovation work. And I don't know, Ben, do you want to speak to this, or I can keep going?
Yeah, I mean, I can go very high level, but I think we can just kind of open it up, talk through stuff together too. These are the colorful boxes you'll see here are the pillars, as we call them. So these are really the drivers of change that are referenced in that purpose. So the purpose of healthcare organizations will make a meaningful, measurable, and transformative contribution to end chronic homelessness across the community. Intentionally broad and vague in its own way, but also something that we think is really important. And really, as we work with each different site, we think of these 5 different levers to understand which one requires the focus and which landscape really lends itself well to, you know, driving things like inflow. We know that there is clear issues with something like housing placements when housing stock is low. And so how can we lean on the other pillars to help drive change as well? Yeah, I mean, I'm happy to.
Yeah, I remembered what I
Yeah,
was
go for
going
it.
to say. So I'll say it before it leaves my brain again. But I was going to say one thing that I think is really exciting about this pilot that doesn't always get mentioned is that in addition to the local health systems that we are engaged with in each community, we're also engaged with the kind of national or the enterprise level systems of KP, Providence, St. Joseph's, and Common Spirit. And you know, I think what is great about that is that as we're doing this local learning, our counterparts at the enterprise level are starting to think about what it would look like to kind of hardwire this into their system. So, you know, as Sacramento, for instance, is working on figuring out data sharing agreements across homeless response systems and healthcare, KP is like, okay, so what would it look like for us to kind of build this into our EHR so that we could kind of quickly and rapidly spread it. So. Yeah, sorry for the short circuit
No.
in my brain. And the other thing I think about this theory of change is that, you know, each of these 5 pillars is necessary, but not sufficient on their own. That's the theory that we're testing, that they kind of need to be done in concert with each other in order to see results.
I would pause and just maybe say, thank you both for that. That was quite an in-depth walkthrough. Great. Use snaps for that. One handed up. There you go. But yeah, I mean, this is the aim that we have up here, but we'd love to kind of just talk through, you know, that we've talked about a lot of things. What does that bring up for you all? What are some questions you may have? We can talk through what we've seen at other sites. We can talk through what we've seen in Anchorage. What's most interesting to the folks in the room and virtually in the room.
Can I ask a quick question? Do you want me to pull back up the team who's virtual so you can see them and take that question?
Yeah,
Sure.
that works for me.
Yeah.
I think, yeah. That's-
I have a question. So
Earlier in the slides, I believe it said you'd reached functional zero with 16 communities. Just a question, what was the commonality? Was there any commonality in the communities? Were they large and small? Was there any common threads? Just kind of wondering how they compared.
Yeah, I mean, the short answer is the common thread is that they were working with community solutions. But I think the truth is that we're still really working to suss out what worked out well and what was the unique kind of flavor and blend of things that happened. I will say that when we say that we're thinking about subpopulations typically, and so, for example, something like looking at the subpopulation of veterans, that's one that I know we've had success with because we have a really close relationship with the VA, and that's there's resources there. There are clear cut, policies in place. And so things like that, I think we're starting to learn more from, and then working on really packaging those into case studies and documents that we can then share kind of open source to the world. But I think right now we have a really wide data set, and we're trying to figure out, how do we make this replicable in some way?
I was just 16 is a lot.
Yeah,
Congratulations. but
Well, yeah, and it's
a lot of data.
It feels great, and also it feels like we should have 100 more.
Mhm.
And so we sit on these calls and we talk to people that are working so hard and so diligently to approach that number, and yeah, the system is tough. And so I think we always feel we're happy with 16, but we're always aiming for higher. So
Yeah, just to add, so 12 ended for veteran, right? 5 ended for chronic, and then 3 ended for both.
yeah.
And it's a broad range of communities which we can share with you. who can reach
Yeah.
solving category.
And one thing that we often will do is when a new community joins Built for Zero, or just someone that reaches out, we're very happy to put one community in touch with somebody who has and did it or in some way or achieved functional zero. It's often just, they've tapped into a system that may not exist in this rural ecosystem or something, but.
Thank you.
Yeah.
I find it interesting in what you're saying from the perspective of SALA. So we got started working in the municipality with the homelessness response through COVID and during the pandemic. And then we eventually went to work with a pilot program for the state of Alaska. They did this mobile integrated health program in the state, and it was there was 5 communities basically that did it. And so SALA did the hospitals here in Anchorage and in the Matanuska Valley up in Palmer. And the goal of that program as it was originated was to reduce the surge in the hospitals. It was when the Delta wave came along and there was a lot, the hospitals were at capacity and we were at crisis levels here. And so the purpose of that was to be able to discharge otherwise stable individuals into the community. Well, we found with that we got, in addition to just the work that we were doing in the congregate and non-congregate settings for the homelessness, at that point, we kind of realized there that the folks weren't making it through the healthcare system. They'd reach a point, and you said it earlier about navigating through themselves. They reach that point of having to do that navigation themselves, and they've got a plethora of issues that prevent them from being their own advocates in that case. And so, our medics there at those sites would kind of help, make sure that, okay, you got an appointment this day. We're gonna remind you the day before. We're gonna arrange for your transportation and stuff like that. But then when we went out with the mobile integrated health, we were going into camps. We were going to the complex care at the shelters and things like that. And I mean, lived experience for me was that was absolutely what the majority of these people needed in it to move forward, was somebody that could help them navigate through the process because of their substance abuse or because of their mental health issues or whatever it was that came in there. They just were not able to advocate for themselves. And my training is as a paramedic and a firefighter, and so I spent 20 years as part of the system, just moving one person to the next point of the system, and then not worrying about it after that. And then now that I've been doing this work, I realized that actually there is there is an ability, if you put a little bit more time and effort into it, to actually make an impact. And so you're not just moving people through until they recycle back to the beginning. You're causing a change in that path process to put them onto success. And so, like, I applaud what is going on here. I'm so privileged myself to be taking this on. It's like, I did a full career, thought I had a great career in EMS, and then I start doing this, and I have never been more satisfied with the impacts that I'm having to a community as I have right now, because we're actually, and I'm not an end provider anymore. I'm in the management level, but like, I see my providers making this difference every single day for the most vulnerable people. And it's as simple as knowing their name and addressing them by their name every single day when you see them, asking them how they're doing and being genuine with it. And then just providing them the resources and the education in their place of residency, where they're more receptive to hear and to learn how to manage their own needs. And so this is great, and I am very, very excited to be part of it.
Yeah, thank you.
Yeah, thanks. I want to say, similar to what you're saying about kind of having a navigator in a way, that's something that we've seen in almost every site where it's been, how do we, I think that there's a little bit of the realization we're hearing from all the hospital systems that an individual experiencing homelessness can really not be left to navigate the system in the same way and engage with the system in the same way as an individual in that under different circumstance. And so I think the first part in the pilot was really the acknowledgement of that first. And then it was, okay, now how do we come together? How do we figure out how, on the enterprise level, it's thinking about the business case as well. And so looking at this, the two populations, high utilizers, chronically homeless individuals, looking at that, and all this kind of comes down to the data piece as well. So yeah, I think I just want to like +1 that, and that we're hearing that across the board. And we're starting to see a lot of hospital systems step in and say, we need a liaison. We need somebody that's thinking about discharge or whatever this may be, because I think it's becoming, the same thing you said, you're seeing these individuals engage over and over again. And it's at some point you got to kind of figure out a way out. Yeah.
So the complex care piece, is that what we're trying to accomplish with the sockeye?
Yes. So the sockeye, sorry, we should just call it complex care. We're not allowed to call it the sockeye. Name and the sale agreement.
Okay, all right.
It's not so it is the place where really vulnerable individuals end up, and it connects with really important case conferencing, which is where we start to develop that ecosystem of care. So it's the ADRC case conferencing. And that is really about tapping into mainstream benefit to let folks continue movement toward permanent housing, often assisted living, but sometimes it's eligibility for personal care attendance or something like that. And one of the impetuses for the facility was we were going through that state process for those benefits. It's a long trajectory, and our advocacy efforts haven't managed to shorten it yet. So we were like, we really need a standalone facility to meet the need to really put people in their best position, that when they get these benefits, they're ready to, hopefully go to whatever that placement is. We found a lot of resistance calling up an assisted living home saying, hey, we have someone, they even have money. Will you take someone who's experiencing homelessness, into your assisted living facility? The answer was often no. So we're hoping to show that stability and, opportunity to do that. And also maybe give someone a new perspective on what an assisted living home might be, because this isn't often the first time they're encountering an assisted living home. And doing a lot of groundwork. It's
Thank
really
you.
cool. Really fun to watch. It's really fun to watch the case conferencing when someone gets eligible for benefits. They're really good at celebrating that.
And it can also end in people independently living too, with the supports like Mike said. And we've seen a couple of those that go to vouchers. EPs have been very popular, and having the supports actually stay in their own homes and still have those services that they need to continue to stay there. where they wouldn't have had it before. And so complex care, I think Dave will agree, is a stop in the road for that long process. And it doesn't have to be the stop as we filled out robust outreach, but a necessary one as we're looking at people as they're struggling, you know, with especially mobility issues or incontinence, and a plethora of other. We have a lot of folks that were on chemo and things when we started ADRC, more than I really expected, that are experiencing homelessness, that were going through major, you know, health issues, and that, you know, really have benefited from something like complex care.
Not as helpful for this space because everybody here is totally bought in. One of the things that I find is a little bit of a struggle is getting buy-in, particularly at the macro level. So in places or in communities that have been successful in finding functional zero, what was their approach to like getting people bought into the mission and getting them to like put the resources that, you know, in this time it feels super challenging, like, yeah, we'll do that. I have like, you know, check requests and 9 million other, like, you know, whatever that list is, the to-do list feels really long, and this priority often feels like it's, we'll get there. Yeah. You know, March 32nd, I'll work on it. Do you have any advice about like what you've seen in other communities that we could apply here as far as approaching buy-in?
Yeah, I mean, I think it's the never-ending question in a lot of ways, but I can at least speak a little bit to what I've seen. I think that there's a couple approaches, and one of them really starts with around data, and it's kind of just understanding. It may not be just identifying individuals during a PID count, but working with other systems to identify their involvement and interaction with a certain population of some kind. And I think it's more identifying where you kind of want to end up. And so an example that maybe I would use is like in the complex care shelter, looking for opportunities to, look for trends in the individuals that either are becoming eligible or graduating out of that program, and or even the applications and folks, there. I think that's a really interesting, data set. I know it sounds very inhuman to say that, and I don't like it, but that's a point where you're able to really bring that to a hospital system, a healthcare system with some really strong backing of this is what we're seeing, and understanding kind of how that all rolls into it. And I think on like at least in the healthcare side, it's a lot of also making every participant understand their role and how they would feel the burden of this increased cost and increased responsibility in this way. But largely most of the macro, like non-healthcare related changes have been from really strong will building within kind of a coalition. It's really getting powerful individuals that are on board, nothing shocking here. But I think also what I've seen is that that's not always people that are in positions of power, but maybe people who are influencers within the community, or large systems that kind of oversee things in different ways. There's absolutely a political element to it as well. As national policy changes around homelessness, so does state policy and all the other parts of that. So it gets really complicated in those ways. But yeah, that very long-winded explanation, I would say, like looking at data and kind of thinking through how you could use that to make an argument in a way, and making sure that each player at the table understands how they are impacted by the system as well. Yeah.
I mean, I agree with everything Ben just said. And one other thought I had was, that's one thing that I love about like the quality improvement type approach. We coach around starting really small, like one person, 1 to 5 people, and then kind of just seeing, okay, what would it look like if we did whatever it takes to improve the care and the outcomes for this individual, learning from that one individual, and then kind of expanding from there. But I think that it's almost like the unsung hero of quality improvement is that it also helps to build will. Like people might think like, oh no, there's no way we could do that, or it's at the bottom of the list. And if you show like, but look what we did for this one person, it can be like a great will building tool as well.
So one of the things I've seen, going back to sort of this assisted living home and these things, the system doesn't care about people's social needs. They care about your body and we can feed you and put a roof over your head. Your social needs are not taken into any sort of account. So that's, I've been placing people in and out of assisted living homes for years. And that's, to me, one of the major things that happens. People get there, we go, why won't you stay there? Well, one, oftentimes the people don't speak the same language. The caregivers don't speak the same language. The food often is substandard. It's the bare minimum of what the home can get away from or away with because of the oftentimes many folks come in on what's called the general relief rate, which is the lowest paying rate, but sometimes folks have pretty high needs and the homes don't want to put up with it, or they've been burned by things like that. So you know, one of the bigger successes recently was a gentleman who had bounced in and out of many homes, but we ended up getting him on the Medicaid waiver program. He ended up still trying to use primary care and the hospital for his social needs, going there almost every day, getting very angry when the home wouldn't take him there. We got him into a day program where he can go spend time with other people. He loves it. We don't have any other problems with him because he's out doing his social things every day. But that's one of the other pieces, that the system is very rigid. The only way you get that is by having so many physical or cognitive issues that you're very impaired. But all these folks that are just lower than that don't get their social needs addressed. So oftentimes shelter is where they get those done. So
I think that's a great example of, you know, what Catherine was saying, but also one where, like, outside of this room, I don't know how, you know, in the community, how much understanding there is of something of that, to that nature, you know. I think there's often, and I'm not speaking about Anchorage, but just in general, communities often think if somebody gets housed, that's the end of it, that's a win, that's great. So I think that's like an opportunity for communications and press releases where it's really powerful to paint the full picture and have, you know, that individual or somebody explain why there was, you know, that stickiness to this last placement and what worked about it. And that sometimes will be enough to drive, you know, a new person to the table in some ways.
Yeah, we've really been stressing that. So we have a new housing opportunity that came online, 130 units of new housing at a converted hotel. And we have found 60% of new residents self-selected roommates. And so as we added a housing component to our emergency winter planning, last night, actually in front of the legislative body, they were trying to cap it at a number of people. We said, no, talk about the number of units. And then if each unit can accommodate roommates, make that an option, because one, you will serve more individuals, but you'll get more of that stickiness. You'll get people who want to be there because of that sense of community. And they made that change. We're really happy about that because we see, you know, that's what is making this particular housing project that just stood out really successful, is that sense of community, because people know people already and they don't feel isolated. And so it's really been a really big piece to it.
You know, touching on that and what Celia said, I mean, there's so much to celebrate. I just think back 5 years, the distance we've come. We have a long ways with the general public, but the amount of education that's even happened over the last year and a half, because we've been able to get out in front of the public and segment at least the groups and talk about the complex medical and get in front of the legislative body and make them think through. And so we're getting there with policymakers, with leaders, and we're getting enough stories. And we're just starting to break through just this one-dimensional idea of a homeless person, and at least opening the door to this understanding of elders with complex medical needs, of, you know, this transitional housing. So the conversation, like, we've been on this journey, we've come a long way. It's just, there's so much further to go.
I completely agree with you, Nathan, because 10 years ago, if you said you were going to build an affordable housing complex in this town, everybody would be up in arms. We got past that conversation. Everybody realized the need for housing. It was an education for the public. I think, just as you just stated, I think with homelessness, we're getting to that point too, where so many people think that homelessness is the guy sitting on a corner with a sign, when we all know that's not true. And I think people are starting to understand that. And I think we're starting to make inroads.
In your pilot, or have you been thinking about, so we've been taking the healthcare and homelessness pilot very much from the physical healthcare lens. but the community is crying out for the behavioral healthcare lens. And so would like to hear any thoughts you might have about that, because as soon as the complex care shelter stood up, the very first question was, can we do it all again with behavioral healthcare focus? Because we know we have such huge unmet behavioral healthcare needs, and we would love to approach them in the same fashion. And we do have some tools, but yeah, it's like your thoughts if you have any.
So, yeah.
I was gonna ask if you know, are any of the pilot sites working on?
No, so I mean, in full transparency, we've
Yeah.
had conversations, and I think where we get stuck is that it's a lot harder to define and kind of understanding. And I think that there's just we've seen success in like hospice care and things like that. I think that's much more visceral in a way. And I think there is a very clear correlation that the healthcare systems see in how they would, be taking care of that individual if they were not placed into a system. I think when we had this conversation in behavioral health, they were still figuring out what funding mechanisms would be helpful in that way and kind of where to start. And I think that the idea was that by starting with something like respite care or in one of those other kind of veins, they would be able to prove that they're able to kind of work with a segment of the population and then spread that out. But it hasn't progressed anywhere within our pilot yet.
Okay, yeah, we're being presented the opportunity, I guess is the way I would put it, in our community as we roll through implementing crisis now.
Yeah.
And crisis stabilization centers, and we have a mobile crisis team. So we're starting to be able to build up some of that data. Who are we intersecting with? Who
Sure.
can we triage and stabilize in the community? But then what's next?
Yeah.
And then what's the call frequency and utilization frequency? And then what we do know is if you do go to the psychiatric ER, there's nowhere to go.
Yep.
And so we're really just starting to think through it. We've got a little bit of data, got a little bit of lead time because crisis stabilization centers aren't online quite yet.
Yeah.
But as that happens, then we start to see discharges from stabilization opportunities. We're going to need to be ready to approach that from, the homelessness side. Because we do have a lot of folks who are discharged from the psychiatric hospital or psychiatric ER or having an encounter and they return to homelessness. So.
Yeah. Well, that's absolutely something we could add into the pilot work.
Yeah.
Like that's a great example of kind of the type of project that we are always hoping to kind of dig into. And if nothing else, do some literature reviews and find some folks that we can bring together. And Lauren, who had to step out, is also like a great way to kind of connect some of that. And so we can work with Dakota to make sure that's, top and center as we move forward too.
One of the interesting things, I didn't get a chance to double back, when the Sullivan was first stood up and there was a call to Providence, South Central and Anchorage Neighborhood Health Center to bring a clinic in-house. And I know our director of behavioral health for Providence was working on setting up some MAT, medically assisted treatment around substance use on site. And I'm just curious about how that went and if there was any learning to be done. Because I know the question was asked of David Brittenberg, today Complex Care, whether, MAT or there is any services. And it just seems like in this behavioral health spectrum, the co-occurrence of SUD.
I think it went away quietly when the clinic went away, just for a variety of reasons.
Yeah, it just would be interesting to
Yeah.
learn if there's any.
And there's some data around that, I think. That's one of the reasons our mobile crisis team was stood up with an EMT and a clinician, is we knew there was so much untreated substance misuse and medical needs. It's really hard to encounter someone from a clinical side if they're in physical distress for a variety of reasons. I guess what I'm learning is the mobile crisis team does like a lot of wound care. Just getting someone comfortable, getting them taken care of, maybe testing some blood sugars, but then they're dealing also with the behavioral health issue all at the same time. So I think we could probably start digging into some of that data. We're a little over a year out now since it started, so we should hopefully have some good data.
I think in a recent outreach survey of lived experience, the two primary concerns in congregate shelter were other residents' drug use in shelter or other residents' mental illness in shelter was hard to be around.
Yeah.
So a reluctance to engage with services centered around other people's unmet behavioral health needs. So it's not just the community level, it's at the user end too.
Well, there will be that place opening in next fall for the 50 beds that Prov, SCF and CITC are building in Midtown.
The permanent supportive housing beds, yeah.
Yeah, but
This is Nancy. I have some information on how that MAT clinic went. Renee, of course, would have the most up to date, but the challenge with doing MAT in a congregate setting is the ability to store medications and to ensure that medications go to the person they're prescribed to. And so that became a pretty significant limitation at the Sullivan, which was where the Bridge Clinic was collaborating. There was a decision to try it at non-congregate sites, and I think the system became a bit too dispersed to maintain a focus on that. But recruiting patients into the clinic at Providence was the latest strategy that I tracked before before things changed. So that was the ability of the person to have their own room, be able to store their medications safely, and to lock their door is key for those services.
Thanks, Nancy.
I know we're a bit over time, so thank you everybody for coming. If you have any other questions, you can email me and we can get you back some answers, potentially, maybe.
Thank you all for the time.
Thank you for
Thank
coming.
you. Talking to last time. Have a wonderful time.
Thank you for
Absolutely.
But thank you for coming virtually. We really appreciate it. And there's snacks and coffee.